Neoplasm of musculoskeletal tissues. Remember, it's more important to learn about the general features of this wide variety of lesions, the incidence, the diagnosis, the prognosis, and principles and methods of treatment. Less important, microscopic characteristic of these lesions, interpretation of changes. Neoplasm-like lesions and true neoplasms of bone. Definition of terms: tumor, any localized swelling or lump. Less precise than the term neoplasm. New growth refers to a new and abnormal formation of cells, which progresses throughout the life of the patient. Genetic changes do not reach maturity. Divide by mitosis more rapidly. Progressive lesion. Ability to initiate growth in distant sites. Metastasis, malignant aka cancer. More difficult to define benign neoplasm. Primarily remains localized. May naturally neoplastic. Reactive lesion. Self-limiting reaction to some other phenomenon. Hamartomas, lesions in which cells normally present in a local area grow faster than others, but immature, exist as a useless and harmless cell mass. Fibrous dysplasia, simple bone cysts, do not fit in any of these categories. Classification: share common mesodermal origin, differentiated along a variety of lines: osteoblast, osteoclast, chondroblast, fibroblast, pericytes, myeloblasts. Classification based on the cell origin: osteogenic, chondrogenic, fibrogenic, angiogenic, myelogenic. Classification of neoplasm-like lesions of bone. A. Osteogenic. 1. Osteoma or ivory exostosis. 2. Single osteochondroma or osteocartilaginous exostosis. 3. Multiple osteochondromata or multiple heredity exostosis. 4. Osteoid osteoma. 5. Benign osteoblastoma or giant osteoid osteoma. B. Chondrogenic. 1. Enchondroma. 2. Multiple enchondroma or Olier's dyschondroplasia. C. Fibrogenic. 1. Subperiosteal cortical defect or metaphyseal fibrous defect. 2. Non-osteogenic fibroma or non-ossifying fibroma. 3. Monostotic fibrous dysplasia. 4. Polyostotic fibrous dysplasia. 5. Osteofibrous dysplasia or Campanachi syndrome. 6. Brown tumor or hyperparathyroidism. D. Angiogenic. 1. Angioma of bone or hemangioma and lymphangioma. 2. Aneurysmal bone cyst or ABC. E. Uncertain origin. 1. Simple bone cyst or unicameral bone cyst or UBC. Classification of true primary neoplasms of bone. A. Osteogenic. 1. Osteosarcoma or osteogenic sarcoma. 2. Surface osteosarcoma or periosteal sarcoma. B. Chondrogenic. 1. Benign chondroblastoma. 2. Chondromyxoid fibroma. 3. Chondrosarcoma. C. Fibrogenic. 1. Fibrosarcoma of bone. 2. Malignant fibrous histiocytoma of bone. D. Angiogenic. 1. Angiosarcoma of bone. E. Myelogenic. 1. Myeloma of bone or multiple myeloma. 2. Ewing's sarcoma or Ewing's tumor. 3. Hodgkin's lipoma of bone. 4. Non-Hodgkin's lipoma or reticulum cell sarcoma. 5. Skeletal reticulosis or Langerhans cells histiocytosis. 6. Leukemia. F. Uncertain origin. 1. Giant cell tumor of bone or osteoclastoma. General considerations. Incidence: primary tumor of musculoskeletal, rare, 1% of malignant disease in all groups and 5% in childhood. Benign neoplasm and neoplasm-like lesions, less rare. Secondary neoplasm, metastatic carcinoma. Common, the age is quite distinctive. Osteosa, childhood and adolescence. Ewing's, adolescents and young adult. GCT, chondrosarcoma, fibrosarcoma, middle adult life, older adults, elderly. Sex incidence, less striking. Site incidence and anatomical site within a given bone, significant. During childhood, seem to be related to the rate of bone turnover, greatest in the flared-up metaphyseal regions of long bone, lower end of femur, upper end of tibia, and upper end of humerus. General considerations. Diagnosis. Primary care physician or secondary care community. Orthopedic should be constantly alert to the possibility of such neoplasm in DD, of unexplained pain, swelling, a lump, or a decrease in function. However, the evaluation and treatment of patients with neoplasms are highly specialized, should be referred for further evaluation, including biopsy and definitive treatment to a tertiary care musculoskeletal oncology unit. High emphasis on complete history and physical examination, diagnostic imaging, laboratory investigation, staging of the neoplasm, and biopsy. General considerations. History of recent local trauma usually only brings the pre-existing neoplasm to the attention. Slowly growing neoplasm and neoplasm-like lesions of bone seldom cause symptoms unless interferes with function in surrounding tissues or associated with pathological fracture. Pain is the most significant symptoms of rapidly growing malignant neoplasms, initially mild and intermittent, progressively more severe and constant, interfere with sleep, caused by either tension or pressure on sensitive periostome and endostome, sudden onset of severe pain, complication of pathological fracture, local swelling, when protrude beyond normal confines of the bone, benign lesion, firm and non-tender, malignant lesion, more diffuse and tender. If the lesion is close to a joint, painful restriction of joint motion. From the topic we've discussed before, the first picture is the picture of local swelling or lump on the medial aspect of the left leg just below the knee in a 10-year-old boy. This local swelling, which was firm and non-tender, was due to an underlying osteochondroma or osteocartilaginous exostosis, arising from the medial aspect of the metaphysis of the tibia. The second picture is the picture of diffuse swelling in the region of the left knee of a 16-year-old boy. This swelling, which was warm and tender, was due to an underlying osteosarcoma. The third picture is dilated superficial veins in the left leg just below the knee in a 10-year-old boy. This photograph was taken under infrared light. The skin in the area of dilated veins was warm. The underlying lesion was a vascular, rapidly growing osteosarcoma. General considerations. Diagnostic imaging and correlation with pathology. Plain radiograph, conventional tomography, CT, MRI, scintigraphy, or bone scan. Plain radiography. High quality, well-centered AP and lateral view. Reveal the location and size of the lesion, the resorption of bone, the margins of the lesion, clear or fuzzy margin, the reaction of the bone to the lesion, the effect of the lesion on the cortex, expansion, and penetration. Occasionally discovered by a change as an incidental finding. The pathology of neoplasm with lesions and the true neoplasm, reflected by changes in density of radiographic changes of the bone and soft tissues. Plain radiography. Neoplastic cells do not themselves destroy bone. Inside local osteoclastic resorption of bone. Certain type of cells. Inside local osteoblastic deposition of normal bone. Reactive bone. Group of neoplasm capable of producing osteoid and bone, tumor bone or neoplastic bone. Radiographic appearance reflects varying proportions of bone resorption versus bone deposition. Some slowly growing lesions. Inside it, marked reaction in surrounding bone. The reactive bone may obscure the underlying neoplasm. The deep surface of the cortex is gradually eroded from the inside. At the same time, the periosteum reacts by depositing bone on the outside, expansion of a bone. From the topic we've discussed before, the first picture is reactive bone surrounding a slowly growing benign neoplasm. In this case, a chondroblastoma of the upper tibial epiphysis in a 13-year-old boy. Picture A. In the planned radiograph, the reactive bone almost obscures the neoplasm. Picture B. In the stomogram, the radiolucent neoplasm is seen clearly in the center of the reactive bone. By means of this special technique, tomography, laminography, many films are taken, each of which shows a different layer or slice of the tissue in focus. Plain tomography has been replaced to a large extent by CT. Second picture is expansion of a bone by a slowly growing lesion. The enchondroma in this proximal phalanx is slowly eroding the cortex from the inside. Simultaneously, periosteal new bone is being deposited from the outside. When the rate of erosion exceeds that of periosteal bone formation, the bone expands. Plain radiography. Elevated periosteum due to invading neoplasm which eroded cortex. Reactive bone angle. Cutman's triangle. Elevation of the periosteum in stages stimulates the formation of successive layers of periosteal reactive bone. Onion skin appearance. Malignant neoplasm grows rapidly beyond cortex with its associated blood vessels, grow in radial fashion from cortex, sunburst appearance. Weakened bone by local destruction plus trivial trauma, pathological fracture, heavily depend on regenerative process versus destructive process. First picture shows triangular-shaped areas of reactive bone or Cutman's triangle that have been deposited by the elevated periosteum. In these radiographs of the femur, a malignant neoplasm and osteosarcoma has eroded the cortex and elevated the periosteum. The reactive new bone is laid down around the periphery of the neoplasm in the angle between the elevated periosteum and the cortex. Cutman's triangle is not always so apparent. It is not pathognomonic of any one bone lesion. Second picture shows successive layers of reactive bone that have been deposited by the periosteum as it has been elevated in stages. In these radiographs of the radius and ulna, the underlying neoplasm is a Ewing sarcoma of the ulna. This radiographic onion skin appearance is not pathognomonic of any one bone lesion. The third picture is neoplastic and reactive bone radiating out from the cortex into the radiolucent tumor mass. The bone is deposited along the course of blood vessels that radiate out from the cortex. This accounts for the radiographic sunburst appearance. In the lower end of this femur, the neoplasm is an osteosarcoma. The radiographic sunburst appearance may also be seen in other malignant neoplasm, as it's not invariably present in osteosarcoma. So this picture is pathological fractures through the abnormal area of bone that has been weakened by the local destruction or osteoclastic resorption of a neoplasm. Picture A shows pathological fracture through the osteosarcoma of the lower end of the femur in a 14-year-old girl. Picture B is pathological fracture through one of the two lesions of myeloma or multimyeloma and the humerus of a 43-year-old man. Plain radiography. Rapidly growing malignant neoplasms. Little or no reactive bone. Only osteolytic defect, particularly for osteolytic type of metastasis in bone. Certain neoplasm, particularly one from prostate, inside osteoblastic reaction when meta to bone, osteoblastic or osteosclerotic type of metastasis. The only true cyst, simple bone cyst. Remember though, the radiographic appearance is not pathognomonic. Do not spot diagnosis on the basis of a single radiograph. All available data from the various diagnostic methods must be correlated. From the topic we've discussed before, the first picture is osteolytic type of secondary or metastatic neoplasm in the intertrochanteric region of the femur of a 62-year-old woman. The primary neoplasm was carcinoma of the breast. Picture 2 is osteosclerotic or osteoblastic type of secondary or metastatic neoplasms in the pelvis and femora of a 75-year-old man. The primary neoplasm was carcinoma of the prostate. The metallic clamp is on an indwelling catheter. First picture is simple or solitary bone cyst of the lower end of the radius of a 10-year-old boy. This is a true cyst in that it is a lined cavity that contains fluid. Note also the transverse pathological fracture through the cyst. Picture 2. Osteolytic neoplasm that radiographically has a cystic appearance, but is a solid lesion filled with neoplastic tissue. Hence, it is not a true cyst. This neoplasm in the lower end of the radius in a 32-year-old man is a giant cell tumor or osteoclastoma. Plain or conventional tomography. Sections or slices of the tissues at varying depths from the skin surface has been replaced to a large extent by CT and MRI. Computed tomography or CT. Tissues of varying radiographic densities are more clearly differentiated with less radiation than with conventional tomography. Pivot for accurately depict site and extent of a lesion, as well as keep lesions and soft tissues extension within bone. Better detail for pelvis and spine region. More useful to detect areas of ossification and calcification and subtle pathological fracture. CT of chest can reveal very small pulmonary metastasis. Picture 1. Computed tomogram of the cross-section of both sides. Note the destructive lesion within femur of your right, the left femur viewed from below, and the large extension of the lesion into the soft tissues. The diagnosis is a far advanced osteosarcoma. Picture 2. Computed tomogram of the cross-section of the trunk at the level of the 4 lumbar vertebrata viewed from below. Note the extensive osteolytic lesions of the vertebral body and pedicle. The diagnosis is an aneurysmal bone cyst. Magnetic resonance imaging uses non-ionizing radiofrequency radiation, provides better images of soft tissues, i.e. bone marrow, major nerves, blood vessels, and the relationship of neoplasms to those structures. Provide physiological and anatomical data, especially when combined with contrast and spectroscopy. Bone marrow lesions. Low signal in T1 or dark. Soft tissue extension and soft tissue neoplasm. High signal in T2 or bright. Lipoma. High in both T1 and T2. Fibrous lesions. Low in both T1 and T2. Especially useful in the staging. The first picture is computed tomogram of the cross-section of the chest. Note the multiple tiny radiographic densities throughout both lungs. These metastases that were not detectable in plain radiographs of the chest. Picture 2. Magnetic resonance imaging of both femora of a 13-year-old boy. In this T1 wave image, there is a large low-density or dark lesion in the distal end of the left femur. The diagnosis is an osteosarcoma that has extended from the metaphysis into the epiphysis. This picture is magnetic resonance imaging of both femora of 7-year-old boy. In this T2 wave image, note the extensive high density or bright lesions both inside and outside the proximal area of the diaphysis or shaft of the right femur. The diagnosis is a Ewing's sarcoma of the femur with soft tissue extension. scintigraphy or bone scan. Technetium-99 labeled polyphosphonate reflect changes in the local blood flow in bone, degree of local metabolic activity, increased radionuclide uptake, hotspots, very helpful in revealing lesions which are avascular, skeletal surface. So, this is the picture of scintigraphy. In this technetium-99 labeled polyphosphate total body bone scan of a 5-year-old girl, there are multiple dark or hot spots, both proximal tibia, both distal femora, both proximal humeri, and the thoracic spine. The diagnostic is metastatic neuroblastoma. Laboratory investigations count blood cell, including white cell diff count. In Ewing sarcoma, the ESR level is high. In multiple myeloma and metastatic bone disease, the calcium serum level is high. In hyperparathyroidism, the phosphorus serum level is low. In osteosarcoma and Paget's, the alkaline phosphatase serum level is high. In carcinoma of prostate, the acid phosphatase serum level is high. Carcinoma of prostate, the prostatic specific antigen or PSA level is high. There is abnormal pattern in multiple myeloma and metastatic bone disease. In multiple myeloma, the unary Burns-Jones protein level is high. Staging require plain radiograph, CT, local and chest, MRI, and bone scan. Factors: the histological grade of the lesions, the size of the lesion and its expansion, metastasis or not. Staging 1. Low-grade malignancy. A. Intracompartmental. B. Extracompartmental. 2. High-grade. A. Intracompartmental. B. Extracompartmental. 3. Metastasis. The purpose is to determine the prognosis and to plan the ideal treatment. Should be carried out before the biopsy is performed, if possible. Biopsy. Essential to avoid 2 serious errors. 1. Failure to recognize malignant neoplasm or underdiagnosis. Inadequate treatment. 2. Diagnosis of non-malignant lesion as a malignant neoplasm or overdiagnosis. Excessive treatment. Biopsy should be performed by oncological orthopedic surgeon who will treat the patient. 1. Frozen sections is helpful determining that the biopsy is representative. 2. Definitive radical treatment should wait for paraffin sections. 3. Surgical incisions should be longitudinal to avoid contamination of uninvolved tissues. Open biopsy is more accurate than aspiration biopsy. The final decision reached from CPC. Principles and methods of treatment. 1. The final evaluation should be carried out by oncological orthopedic surgeon. 2. Compassionate communication. Kindly realism. Everything possible will be done to help. 3. The treatment must be based on the accurate diagnosis. 4. The prognosis and the choice of treatment should be considered the quantity and quality of life of the patient. 5. The advantages and disadvantages of the various treatment options should be presented to the patient and relatives. 6. Ideally, the diagnosis and treatment plan should be discussed in CPC. 7. Surgical method must be planned based on all the available data. Methods of treatment. Surgical procedures. The most effective treatment, either alone or with chemo, include intracapsular or intralegional resection, curettage, marginal resection, or narrow margins beyond the capsule, wide local resection or wide margins, radical resection, or all large part of the involved bone plus soft tissues, such as limb sparing or limb salvage procedures and amputation or disarticulation. The long-term survival rates are much more same between LSS and amputation. LSS requires no skip lesions. The lesion is resectable without jeopardizing the function of the limb. Feasible reconstruction of the residual defect. Reconstruction is large wound allografts, arthrodesis, or custom-made endoprothesis. The complication of massive allografts, significant infection rate, delayed union, and late pathological fracture. The complication of endoprothesis, late loosening, mechanical failure. The alternative is rotationplasty funness procedure. So this is the picture of bone grafting with fragments of cancellous bone to fill a defect after curettage or curetment of a non-malignant lesion of bone. Methods of treatment. Chemotherapy depend on anti-neoplasma activity of the agent, mechanism of action, and biology of the neoplasm. Neoadjuvant preoperatively, adjuvant postoperatively. Toxic effects. Neutropenia, thrombocytopenia, wound complications, infection, nausea, alopecia, and delayed healing. Effective 2. Osteosarcoma, Ewing's, malignant fibrous histiocytoma, childhood rhabdomyosarcoma, relative resistant, chondrosarcoma, fibrosarcoma, and soft tissue sarcomas. Can be grouped into ankylosing agents, such as cyclophosphamide and cisplatin. 2. Antioplasm antibodies, such as doxorubicin and actiomycin D. 3. Folate antagonists, such as methotrexate with cytoferrum rescue. 4. Antimetabolites, such as mercaptopurine, and 5. Fluorouracil. Methods of treatment. Radiation therapy, often combined with surgical and adjuvant chemo or both. Thank you.